is Frank Tillman. I am a PGY2 psychiatric pharmacy resident at the UNC Medical Center in Chapel Hill, North Carolina. There are many challenges in taking care of patients within the psychiatric health community, but I think the biggest challenge oftentimes is fighting that stigma, whether it's stigma amongst patients or family members or even sometimes other healthcare professionals. I know one thing that I come across a lot is this concept of let's just get psych on board and it's just a check mark. Let's just give them an SSRI, which is a select serotonin reuptake inhibitor for depression. Let's just give them these things and then we checked our box, but not actually going into the depths of having those conversations with the patients, addressing what their needs are and understanding where to meet the patient at. The analogy that I like to oftentimes tell people is that you would never tell someone who has heart failure to just get over it, because they're not going to get over it, right? You can't just tell someone who has congestive heart failure to just get over their heart failure and expect them to be better. And I think likewise, we can't expect the same for patients with psychiatric illness. And so I think when I have those conversations with people, the light bulb shines a little bit, which is amazing to see. And so I do think that that is a huge challenge. But I think for any healthcare professional who enters into a career within psychiatry, a part of your role is fighting stigma. And it's something that maybe unbeknownst to you that you sign up for, is to be a champion of fighting that stigma continuously. So I would say that that's definitely the biggest challenge in psychiatric patient populations. And a lot of them have really poor insight into their illness, and they're not aware of the fact that they're sick and that they're ill. Patients with heart failure, they have those symptoms and they're aware. And so that is challenging, but I think the stigma at the end of the day is probably the most challenging. I can deal with the poor insight into illness. We can make them better, but stigma is something that I'm continuously advocating for on a day-to-day basis. A huge disparity is a disparity when it comes to socioeconomic status and when it comes to race. If you look at our prison systems, you oftentimes will see that a lot of our prisons are full of individuals who have significant psychiatric illness and who needed treatment, as opposed to being locked up in a prison and being institutionalized. We've gotten better as a society over time in this, but I do think that we've got ways to go. And it definitely impacts our homeless patient populations, our individuals experiencing homelessness when it comes to that socioeconomic standpoint. All too often, these individuals are seen as non-contributory to society, and where else do we put them but to institutionalize them as opposed to getting them treatment? So I think that that's a huge barrier. As a society, again, I think that we are making strides year by year, decade by decade, but I do think that we have room to go. And I think that another barrier in general is just making it to that appointment or to that clinic visit, or if you need to be hospitalized, being willing to be hospitalized. And I think that really goes into the fact that what we see in media and our media portrayals of mental illness doesn't always align with what it is in reality. And I think a lot of people have that misconception of what it means and what it looks like to have and to live with a mental illness. So those are some of the barriers to care. But then also when we look at some of our most vulnerable patient populations, like our rural communities, there's not that great of access to psychiatrists in those areas. A lot of times those individuals have to go to their primary care doctors, and primary care doctors do an amazing job of treating depression and anxiety and so many other things. But imagine those patients who have severe schizophrenia or severe bipolar disorder, and they're in those rural areas and might not have access to a specialist in psychiatry. And so there's so many disparities, whether it's socioeconomic status, whether it's race, whether it's geographically a disparity. But the good thing that I feel confident about is that we are continuously to move in that direction. The conversations are starting to happen at a more national scale. And people are starting to more and more realize the impact, especially during COVID, where mental illness has taken a huge impact. I think these conversations are starting to get on the forefront of more people's minds, which is good. A huge thing about destigmatizing mental illness as a pharmacist is largely about language. So there are certain things that I have eliminated completely from my language and replaced with more appropriate terms. One example is committed suicide. Why is that an issue, right? Well, using the phrase committing suicide oftentimes has this connotation of someone committing a crime. For instance, you commit crimes, you commit adultery. It's kind of like it's sinful nature to that phrasing. So instead, I replaced that language with die by suicide or attempted to die by suicide. And so that's just a minor change that can hugely help to destigmatize some of the issues. Another way that pharmacists can be influential in this is in the way that we counsel our patients. So oftentimes patients come in and they have these psychiatric illnesses, whether it's depression or anxiety, and they've likely been told time and time again, we're going to give you medications to change your behaviors. These medications are targeting your behaviors, and our hope is that your behaviors are going to change. But really what these medications are doing are targeting neurotransmitters in their brain, different monoamines that are working in a impaired way, not working the way that we would want them to be. And so a huge part about that is saying, hey, you've had X, Y, and Z symptom, and from our knowledge and from what we study and from what we think we know based off of the data that we currently have, it's likely that you have dysregulation of X, Y, and Z neurotransmitter or monoamine in your brain. And so it's not your fault that you are having these symptoms or that you're having these thoughts or that you're feeling this way. However, we do have medications that can help with that. Just like diabetes, where you have impaired insulin or you're insulin resistant and you take medications to help that, well, we have medications that can help those neurotransmitters in your brain that are causing you to have these symptoms. And so I think that language and that approach really makes the world of difference to a patient, because no one wants to be told that they're crazy. The message definitely comes better when you say, hey, you're not crazy. That's definitely not the issue, but you are sick and it's an illness. And so really presenting mental illness and even addiction as an illness as opposed to a behavior is very, very primary on my list, and something that I've seen time and time again with numerous professionals who work within psychiatry. Person-first language is very, very important. So usually whenever I'm referring to a patient, I always say a patient with depression or a patient with anxiety, a patient with schizophrenia, rather than saying I have a schizophrenic patient, because it's important to identify people as people first and to not label someone by their diagnosis. We know that we have very complex social identities. We have various different aspects that make up our identity. And we each know that there's not one part of our identity, especially a disease state, that trumps all the others. And so to label someone as a schizophrenic patient is really belittling in many ways, and will definitely make it harder for them to be on board with their treatment plan. And I think likewise, when we're not even thinking about a disease state, we're just thinking about the various social identities, right? When you think about the fact that as a psychiatric pharmacist or a pharmacist in general, you will likely have a patient who is gay or lesbian or transgender or asexual or pansexual, etc. And understanding that it's always best to ask the patient or ask that individual how they would like to be referred to, or what their preferred pronouns are, or how they would like to be gendered, if at all. And so usually whenever I have instances where I'm not completely certain, especially as a cisgender heterosexual male who has that privilege to just walk into a space and not feel the pressure of people misgendering me, I always like to ask, what are your preferred pronouns? Sometimes it can be an awkward question just as someone who doesn't always know the right things to say, but just taking that step forward from what I've experienced has been influential and has made the world of difference to make individuals feel more welcome and more part of the team if they're your colleagues, or to really feel engaged with the treatment plan if they're a patient. I recently was very, very fortunate to be one of the recipients for an ASHP grant to promote our work at UNC around diversity, equity, and inclusion. And so this grant idea actually spawned out of a Leadership in Motion project, which is essentially a project that we do within my residency as a component of our leadership certificate, which is completely optional. We can do anything that is identified as a need for the department that incorporates aspects of leadership. And me, someone who's always been interested in diversity, equity, and inclusion, what else to do but to try to do something to promote diversity, equity, and inclusion in my workspace. And so luckily for me, I work in a place that is willing to work towards becoming champions for this initiative, to welcome it in an embracing way, and to welcome it with excitement as well. And naturally, we know the incidents from the summer of 2020 with George Floyd and various protests around the nation with racial injustices and inequalities. And so this was right around the time where we were beginning to develop this work. And so essentially, we've been working on a diversity, equity, and inclusion educational series for residents. Our thought process behind this is that we know that at UNC and likely at other institutions, I'm certain at other institutions, that residents are getting top-notch training in the clinical space. Residents are learning how to take care of very complex patients in ways that you just can't get oftentimes outside of residency training. They're learning how to manage projects that impact the system level of their various healthcare institutions. But one thing that's missing is that formal training on how to be a champion for diversity, equity, and inclusion, how to address these patients who have various types of social identities, various backgrounds that have engaged and interacted with healthcare in various different ways and likely have different health outcomes, all based off of their social identity. We learn time and time again that race and gender and all these things are risk factors for various disease states, but why? And what can pharmacists do to be a change agent in that? And so that's what the purpose of our DEI educational series is to have select blocks every 2 to 3 months. We focus on different aspects of diversity and of equity and inclusion. Some of those blocks have been things like race and ethnicity. We've also done a gender and gender identity section, sexual orientation, as well as a focus section on the LGBTQIA community. And then also now we're currently focusing on social determinants of health. We've embarked on this as a commitment to ourselves, as a commitment to our patients. It's been something that has been phenomenally exciting. And it's even more exciting because I get to see this impact on my peers and on my colleagues. And with working in psychiatry, just knowing that my patients don't just come in with schizophrenia and bipolar, they have various other comorbidities. And so just knowing that my peers are being trained to take care of my patients who will ultimately go out into the community and interface with people like them or them themselves just makes me feel the world better, knowing that there are like-minded people in healthcare who are equally interested and invested in doing the work and learning how to practice in an equitable way. So that's a little bit about our work at UNC around this grant and around this realm of work. And we're just meeting this with so much excitement and so much energy. Just can't wait to see how things turn out. Sustainability is something that's very, very important and something that we all should be thinking about when we're discussing how to impact consistent change for our patients, especially when we're thinking about our vulnerable patient populations like our psychiatric patient populations, as well as more broadly our underserved patient populations as well. And I think that the biggest thing, or maybe one of the most influential and impactful ways to really secure that change, is to make sure that at an institutional level, at our various institutions across the board, that we're investing the funds in doing so, that we are identifying those needs that are unmet and identifying the financial implications of addressing these changes. Can we build FTE that can support this endeavor on a consistent basis? And let's also be vulnerable at an institutional level all throughout the nation. Let's be vulnerable and let's do that research so we can understand the gaps that we have at our various institutions, identify those gaps so that way we can understand how to address those gaps for our underrepresented and underserved patient populations. I think that might be the biggest thing across the board to help address some of these issues on a consistent basis. But again, I say this with the thought that I've been in healthcare as a student for 6 years. I started pharmacy school 6 years ago. And I can say that from my time of starting pharmacy school until now, I've seen consistent and impressive improvement at a national level. I've seen institutions make remarks in situations where 6 years ago, I don't think I would have seen that, or I wouldn't have expected it at least. And so I do think that the discussions are becoming more and more prominent. So I'm really looking forward to the future of what this looks like from a sustainable standpoint across the board.